Welcome, Ashley. We were very interested in the research that you're doing, especially around Medicare in the U.S. And interestingly, in the United States, you have essentially national legislation and regulations around essentially a universal policy, which is very Canadian-esque, but yet we in Canada don't have that. Can you just say a little bit about what the Medicare program is in the United States?
Medicare is universal health care for the elderly and disabled. So people with end-stage renal disease, for example, can be part of Medicare even if they are not 65 years or older. So this is primarily elderly people in the U.S., but also some disabled individuals. And there are four components of Medicare. There's Parts A and B, which are respectively hospital and physician care. Mm-hmm. There's Part C, which is sort of wraparound comprehensive care that is Medicare Advantage. It's implemented by private firms. And then there's Medicare Part D, which is prescription drug insurance, a voluntary benefit for the enrollees.
Very good. Well, Part D is the subject of your current research. Can you talk a little bit about that, how it's structured? And I would be most interested to know about the famous donut hole. That's the technical term for it, I'm sure.
The technical term is the donut hole because it looks like a donut, right? It doesn't look like a donut. Medicare Part D came into being as part of the Medicare Modernization Act of 2003. It had its first enrollees in 2006, and it provides prescription drug coverage either as a standalone prescription drug plan or as part of a Medicare Advantage plan that covers other services. What's interesting about Part D is that it's offered by private insurers. So in some sense, it's a public-private partnership. It's the federal government contracts with all of these private insurers who may have been operating in other insurance markets prior to the institution of Part D, but now they are offering these prescription drug and Medicare Advantage plans to elderly enrollees in Medicare Part D, and they have a lot of leeway to set their plan characteristics. They can vary their premiums, their pharmacy networks, their cost-sharing characteristics. There are a lot of dimensions in which they can vary. The argument being that this is an opportunity to offer consumers choice in addition to encouraging competition on the supplier side. So encouraging insurers to compete on the margin of offering lower premiums for high quality coverage.
The program started, I think, in 2003 with its enrollees in 2006. Was it replacing a program or was it new from scratch?
Yes, so some people did have prescription drug coverage prior to Part D. Generally, they had that coverage through retiree plans, so employer or union-based plans often offered prescription drug insurance, just the same way many private employer-based plans in the U.S. offer prescription drug insurance. But also, Medicare enrollees prior to that, and they still do, had the option of getting a top-up wraparound plan called Medigap. And this would cover some of the gaps. This is why it's called Medigap. It would cover some of the gaps in insurance under Parts A and B. So you could get prescription drug insurance, and you could also get coverage of your deductible cost sharing and sort of what's left over once the Medicare coverage runs out in hospital services and prescription drugs and physician services.
So tell me a little bit about the structure, the co-payments and the donut.
Yes, well, it's very funny, actually. So Medicare Part D plans have a very non-standard benefit structure. They have a deductible and an initial coverage phase, which is very common in insurance products. But then they have an additional donut hole in coverage, which acts like a second deductible, but it's a very long period. So it's $2,000 in spending, where the individual, if they don't have additional coverage in that phase, has to pay all of their prescription drug costs out of pocket. After they pay up to a certain total limit in out-of-pocket costs, then they receive catastrophic coverage. And at that point, they pay very little, 5%, a few dollars per fill.
So if you looked at the population as a total, what sort of ballpark percentage would fall into that donut or prior to catastrophic coverage?
So about 30% of people end up in the donut hole. That doesn't say anything about where in the donut hole they end. It could be, relatively right after entering the donut hole or later. Only a few percent of people actually enter the catastrophic phase. So, 20% or more of people will end up in the donut hole.
Now, what got you interested in this particular piece of policy?
Well, I'm very interested in information problems in healthcare and consumer decision making, and I think this is a very good context in which to study information problems. So, Medicare Part D enrollees have to make a lot of complicated calculations about which plan they should choose based on how expensive they are, based on how comprehensive the coverage is, and then once they've chosen a plan, they need to decide how to consume their prescription drugs throughout the year. Some of the prices that are available in these kinds of plans are not very visible, and so understanding as an economist how some of these variations in visibility, variations in coverage end up being internalized by the consumers when they're making their decisions are important, from an economics perspective because we care about decision making, but they're also important for the national budget.
And I'm just thinking about the complexity of the plans and the pricing and the changing structures. And given the age demographic for whom this program is applicable, how well able are they to contend with this complexity? Is it something that for them is a benefit because there's so much choice, or is it overwhelming in some cases?
The evidence seems to suggest that it's overwhelming in many cases. My co-authors have done a previous study looking at prescription drug plan choice in the Medicare Part D context and have found that only about 10% of Medicare Part D enrollees choose a cost-minimizing plan for them. So all of this variation could be a good thing, but it doesn't translate into optimal decision-making in practice. When you move to looking at utilization rather than prescription drug choice, it seems like there are several behavioral biases that lead to suboptimal decision-making throughout the year for many enrollees.
How well do you think this program aligns with the objectives for which it was established in the first place?
I think the results of the plan have aligned fairly well with the initial goals of the plan, those goals being increased financial risk protection for the elderly, increasing coverage of prescription drugs, improving medication adherence of the elderly. Obviously, we think that there are some improvements that can be made. Certainly, my research and that of my co-authors, John Gruber and Jason Abeluk, would demonstrate there are some improvements that can be made. However, overall, I think it's been a good program.
So, in terms of improvements, what are a couple of things that you'd like to see changed?
Well, I think that closing the donut hole is a good idea. That's something that's has been changed under the Affordable Care Act, and it's being changed. The donut hole is being filled in on a stepwise basis through the year 2020. By the year 2020, there will no longer be a donut hole in coverage, which I think is a good thing because the results of our study certainly seem to demonstrate that people don't respond well to that donut hole.
Okay. Well, I couldn't possibly allow you not to give a comment on Obamacare, about which there has been much controversy. So generally in terms of policy directions and the structure of the plan, those two things, policy directions, what view do you have on the overall policy direction of Obamacare?
So I think that it's a good idea. A lot of the policies that have been implemented under Obamacare and that are going to be implemented under Obamacare are very good ones. Correcting some of these really substantial market failures in the insurance market is going to improve equity and access to health care substantially, and I think that's a wonderful thing for the country. I am somewhat skeptical about some of the cost reductions that have been proposed under the Affordable Care Act and some of the projections. I think that, not that I don't think they're going to happen, but that I think there's some uncertainty about how quickly we're going to achieve cost reductions or bend the cost curve. But overall, I think correcting these market failures is a first order good thing to do.
So with all of this activity, there's certainly a lot of wonderful scope for economists to do work Do you see the field that you're in growing, at least in part, because of the interest that young economists might find in this new and fascinating field?
Yes, absolutely. I think that, first of all, it's important. It's 18% of our economy, so we care about 1 in 6 of every one of our dollars and figuring out where those dollars go. Second of all, it's important for our concept of social well-being. So health is important. Without health, what do we have? But also there are some really interesting economic questions, and the availability of data to analyze some important economic, especially microeconomic questions, using administrative data from all of these huge databases that are available in healthcare specifically is a wonderful opportunity for health economists and economists more broadly. So we get to answer questions about industrial organization, about behavioral economics, decision making in the presence of market failures, decision making in the presence of deviations from rational expectations, bargaining models, game theory. I mean, I think it runs the gamut. I think there are a lot of wonderful questions, and now we have a lot of great data to look at them.
Well, you certainly did a wonderful presentation for us here in the Queen's School of Business, and you had a large audience, and from all across the university, from the medical school and the School of Policy Studies, the economics department, and economists here, undergraduate students. So thank you very, very much for a wonderful talk. I've been speaking with Professor Ashley Swanson from the Wharton School. Ashley has delivered the first address in the Monieson Centre for Business Research in Healthcare, Economics in Healthcare Speaker Series. We're very pleased to have her here today.